In this module, we are going to cover different incision designs. There are 6 basic designs that we're going to cover: an external bevel, an internal bevel, a sulcular, a releasing, a thinning or dissecting, and finally a periosteal releasing incision. Let's start with the external bevel incision. External bevel incisions came into prominence in order to do an external bevel gingivectomy. It is a resective incision that is intended to reduce the thickness or the amount of mucogingival tissue. It differs from an internal bevel incision in the angulation of the surgical blade. You can see in this approach an apical to a coronal direction is used to reduce the thickness of the tissue. Below, you can see a Kirkland knife being applied in this fashion, where an external bevel gingivectomy is being performed. Again, this type of incision is done whenever there is gingival enlargement, sometimes for crown lengthening when you have adequate keratinized tissue, and also for a gingivoplasty procedure. The next incision we want to cover is an internal bevel incision. This goes by 3 other names, namely an inverse bevel, a reverse bevel, or an inverted bevel. It too reduces the thickness or the amount of mucogingival tissue, but is directed opposite of an external bevel. In this particular incision, the surgical blade is directed in a coronal to an apical extent. This incision is done when you have adequate keratinized tissue and you need to reduce some probing depth. You can see on the right this incision design being applied as the primary incision in order to reduce the thickness of the tissue. Typically, this is the go-to incision whenever we're thinking about open flap debridement and we have adequate keratinized tissue, crown lengthening with adequate keratinized tissue, and sometimes in dealing with gingival enlargement cases. The third incision we want to cover is a sulcular incision. This sometimes is referred to as a curvicular incision. It's selected if preservation of all the existing keratinized tissue is desirable. The scalpel blade is inserted into the gingival crevice parallel to the long axis of the tooth and angled to the crust of the alveolar bone. Interproximally, this incision is extended as far as you can into the embrasure space to include as much papillary tissue as possible with the flap. On the right, you can see a sulcular incision being done in order to preserve all of the keratinized tissue present around these anterior teeth. This is done when preservation of gingiva is critical, such as in aesthetic areas or areas where minimal keratinized tissue exists. It is frequently done whenever a guided tissue regeneration procedure is performed. Our fourth incision we want to review are releasing incisions, and typically these are vertical incisions that are done. These are done perpendicular to the gingival margin at line angles of the teeth. They are done to increase access to the alveolar bone, enhance flap mobility, facilitate lateral coronal flap advancement, and limit the inclusion of non-diseased sites in the surgical field, or to decrease tension on our retracted flaps. Again, the favorable position for these are, as you see in these bottom diagrams, where they're placed at line angles. If they're placed interdentally or over a tooth root mid-facially, you run the risk of developing an area of recession or dehiscence. There are several things we have to think about, namely anatomy in the area when we're doing this. Again, we do these to increase access, avoid non-diseased sites, eliminate flap tension, and sometimes to help facilitate flap positioning. Anatomically, we have some contraindications to using these. One primary example is distal to mandibular second molars, and this is due to the proximity to the lingual nerve. Some facts that you should be aware of is the position of the lingual nerve in this second to third molar area. We have a couple of studies that have given us this relationship and something to keep in mind. Kesselbach in 1984 told us that the incidence of the lingual nerve sitting on top of the alveolar crest in this region was about 17.6% of cases. If we're thinking laterally on the lingual plate, Benny in 2000 reported that the incidence of the lingual nerve laying on the lingual plate is about 22%. You can see that it's possible that in a quarter of your patients, if you place a vertical releasing incision in this area distal to the second molars, you could induce a paresthesia. Typically, the lingual nerve is lying about 3 millimeters lateral to the lingual plate and about 2 millimeters apical to the lingual crest. Another time when you may not want to do this is if you have any type of bony exostosis over the area. Last, prior to doing any type of surgical procedure, you should sound the defect. And bone sounding is something where we're inserting the probe and taking it to the depth until we stop on alveolar bone. If, as on the right, you have no interproximal bone to support your flap and you place a vertical releasing incision, you're going to end up healing this area with a cleft and not getting the result that you want. The next incision we need to cover is a thinning incision. And thinning incisions are either an internal or an undermining incision that extends from the gingival margin toward the base of the flap in order to decrease the bulk of connective tissue on the underside of the flap. Typically, they are applied as you see here with a palatal flap. This can also be done for distal wedge procedures with an internal bevel gingivectomy, or if you happen to have just a bulky interproximal papilla. On this clinical photo, you can see, as a result of doing the thinning or the dissecting incision, where you have a large amount of connective tissue that you're going to be able to remove in order to facilitate your probing depth reduction. Our last incision we need to review is a periosteal release incision. These are done in order to release flap tension to allow coronal advancement of the flap. Here you can see a scalpel blade being applied at the base of the flap, which severs the underlying periosteum. This creates that flap mobility in order so that we can attain primary closure. Typically, these are done whenever we need to do a regenerative procedure, such as guided tissue regeneration around teeth, or in a guided bone regeneration when we're trying to rebuild an alveolar ridge. This concludes our session on incisions.